And let's continue on with chapter 17, the endocrine system. I do want to kind of reiterate, as you're going through the endocrine system here and going over these different hormones and how these glands are affecting one another in the target cells, keep in mind, we're still going to follow that same concept that all of this begins with the stimulus. And we need a receptor to monitor whatever that stimulus is. And then we're going to send that information, that sensory input information from the stimulus to our control center. In this case, it's going to be the endocrine system, something in the endocrine system. And in most cases, we're going to be dealing with the hypothalamus. Then our control center is going to effectuate and figure out, what the response is going to be and send out that response through, in this case, other hormones to the target cells to effectuate some sort of response. So that's the pattern that we're going to be looking at here as we go through these different types of hormones. So we're going to start off here with the growth hormone. And this is really important, especially for younger folks, because you're creating a significant amount of growth hormone compared to somebody that's in their 80s. And so when we're looking at how we regulate growth hormone, of course, we're going to be dealing here with what type of hormone that the hypothalamus is going to be releasing. Is it going to be releasing, growth hormone releasing hormone or growth hormone inhibiting hormone? Because we said that the hypothalamus releases regulatory hormones. What that means is that those hormones are going to regulate what is going to occur in other glands. And it's a binary type of scenario, meaning it's either going to turn it on or turn it off. So it's going to cause another gland to release its hormone, or it's going to inhibit that gland from releasing its hormone. So let's look at some of the stimuli that are going to effectuate, I'm saying that word a lot, that are going to stimulate or cause the hypothalamus to release its growth hormone releasing hormone. So a person's age, younger people, are going to be more prone to releasing more growth hormone releasing hormone. The time of day plays a role. The nutrient levels that are within your body, obviously, and then of course, stress and exercise. So what we'll see when the hypothalamus releases growth hormone, releasing hormone, it's going to stimulate the anterior pituitary to release growth hormone. Growth hormone is going to go circulating throughout the circulatory system, and it's going to make a stop at the liver. And it's going to cause the liver to release insulin-like growth factors. And so those are similar to growth hormone. The nice thing is, too, is that they have a longer half-life. So growth hormone and IGFs are synergistic to one another. So all the cells in your body will have receptors for growth hormone, IGFs, or both of those individually, So individually growth hormone, individually insulin-like growth factors, and then of course, receptors for both. So we're going to see when growth hormone makes contact with its target cells, that it is going to increase protein synthesis. Well, as we learned back in Bio 210, is that proteins are everywhere. They do so many different functions. Transport, movement, they're involved in, synthesis of hormones. So proteins do quite a bit. Not only will growth hormone stimulate increased protein synthesis, but it's also going to stimulate cell division, which is very helpful when we're growing, and then cell differentiation. We get those, I won't call them primitive cells, but those embryonic stem cells, and then they need to differentiate into a specific type of cell line, so we can generate a specific type of tissue. So what we'll see when growth hormone is released is that it's going to affect how we are going to utilize nutrients that we kept in storage, or what we're going to do with any nutrients that we might put into storage. So you see a list here of 5 bold-faced words, We got glycogenolysis, gluconeogenesis, glycogenesis, lipolysis or lipolysis, and then lipogenesis. Again, let's break these words down to really understand what we're talking about. Lysis is to break down, genesis is to make. Okay, so anything ending in lysis, we're breaking whatever is in that word. So glycogenolysis is the breakdown of glycogen. As you recall, glycogen is the storage form of glucose. So what happens with the effects of growth hormone is that glycogenolysis is going to be stimulated. Why? Because we need to, going back to this slide here, all right, we need to, where am I looking at? Oh. Nope, I thought I had it in the slide. Anyways, if we're going to grow and we're going to help build things, we need ingredients. So we need to make sure that we have plenty of nutrients available to grow the body, to grow tissues. And so we will have to liberate some of those stored nutrients. So that's what we're doing with glycogenolysis. We are liberating, right, that stored form of glucose from glycogen, okay, out into circulation. Also, right, gluconeogenesis is when we're going to use non-carbohydrate sources to make glucose. So for example, we'll convert amino acids into glucose. So we're going to stimulate this process also, gluconeogenesis. Well, at the same time, we are going to stop the synthesis of glycogen. We don't want to work against ourselves here. So we're going to inhibit, all right, glycogenesis. We don't want to start to take what the substances, the nutrients that we've just liberated and have gotten into circulation, into our circulatory system. Well, we don't want to take that back out prematurely. So we're going to inhibit glycogenesis. We're also going to inhibit lipogenesis, the creation of triglycerides, okay? Because triglycerides are a great energy source. We need that energy, all right, to make proteins, to have cells divide, to have these cells to differentiate. And then finally, our lipolysis, we're going to stimulate lipolysis. We're going to break down those triglycerides, right, so we can create energy sources. So this picture here is an awesome picture. I would suggest that you look at all of these figures as you go through each and every individual hormone through this chapter. Starting off here with our stimulus, okay? How old we are, what time of day it is, what the nutrient levels are in the blood, and of course, stress and exercise. And of course, let's not forget negative feedback. Recall the negative feedback loop is when our response to a stimulus is always going to be in the opposite direction of whatever that stimulus was. Okay, so any of these stimuli will be picked up by receptors in the hypothalamus, and that hypothalamus then is going to then release, all right, if there's not a lot of growth hormone present, then it's going to release that growth hormone releasing hormone, right, into what we talked about last class, the hypothalamo hypophyseal portal system, that blood system that connects the hypothalamus to the anterior pituitary. And it's going to stimulate the anterior pituitary to release growth hormone. And so growth hormone will then circulate throughout the body. It'll make its rounds over here to the liver, and it'll stimulate the hepatocytes there to make that insulin-like growth factors. All right, there's insulin-like growth factors 1 and 2. And those will get dumped into the blood. And both growth hormone and IGFs will act synergistically with one another on our effector cells. All right, and if you can see, all the cells in the body are pretty much going to be, not the effector cells, excuse me, the target cells. So obviously, we can see its effects on bone tissue. It's going to stimulate, all right, bone tissue to increase. Osteoblasts are going to start to make more osteoid and will start to grow. We'll also stimulate the reproduction or the division of our chondroblasts and the epiphyseal growth plates there. All right, same thing with muscle, protein synthesis. We're going to make actin and myosin and help to make those cross-bridging sarcomeres so we can grow our muscle tissue. All right, and then we just went over that list of everything that was going on there when we talked about gluconeogenesis, glycogenolysis, lipolysis, lipogenesis, all that is going on in hepatic tissue and also our fat tissue here. So again, our goal is to release nutrients into the blood as we're needing those ingredients to make things, to grow. Okay, so anything that can help take things out of storage and into circulation, we stimulate that. Anything that is going to take stuff out of circulation and put it into storage, we're going to inhibit that. Okay, so I would strongly urge you to take a peek and kind of work your way through this. Turn it into a story, whatever you would like. All right, so you can see the effector cells here. And once we get to the desired effect, then we're governed by that negative feedback loop there, which will then help to decrease the amount of growth hormone that is going to be produced by the pituitary gland eventually. All right, we're on that big feedback loop there. So you can see here, these slides here kind of show you, all right, as we get older, all right, how our growth hormone kind of falls off. So usually it's in pretty high amounts in our early childhood, throughout our teenage years and through adolescence. But then as we enter into our 20s, it starts to decline. And then every decade after that, it just keeps getting less and less and less. You still produce it. And again, we know why you produce it. It's based on any of these stimuli here. Okay. But obviously the one stimuli, age, right, that becomes less relevant as we get older. And you can see here during the time of day, you'll notice how we produce quite a bit of growth hormone in our evening periods if you're on a normal 24-hour circadian rhythm, that sleep-wake cycle. So you'll start to produce growth hormone in the latter part of the day and throughout sleep until the early hours of the morning. So actually, if anyone is curious and if you have children, it's actually good to let your kids go to bed hungry. And the reason why is insulin and growth hormone are antagonistic hormones of one another. Okay, there's only one hormone in your body that really does what insulin does, and there's like 6. There's numerous other hormones that are antagonistic to insulin. Okay, growth hormone is one of those. And so one of the problems is if you give the child a late night snack, say before they go to bed, they're going to be releasing insulin at a time that they really shouldn't be releasing insulin. And because of the antagonistic effects there, that increased insulin is going to decrease the growth hormone. So that's why I never felt bad sending any of my kids to bed hungry, because I knew it was going to stimulate their growth hormone. And I was doing them a favor, and they'll thank me when they're older. I just have this feeling. Okay, let's move on to the thyroid gland here. Yes, mom guilt be gone. You don't need it. Yep. Trust me, you don't have to worry about that. I actually gave a presentation on how it's okay to let your kids go to bed hungry. I mean, that wasn't the whole purpose of the presentation. But anyways, oh yeah. No more cereal right before bed. Okay, so let's take a peek at the thyroid gland first, and then we'll talk about what the thyroid gland does. All right, so if you recall back in 210, when you first stepped into the lab class, we were actually labeling various structures, and the thyroid cartilage is one of the first things that I show to students for that class, the second being the thyroid gland. So you need to remember where the thyroid gland is located. Yes, it's in your throat or neck area there. It is below the thyroid cartilage. And we will see it in front of or an anterior to the trachea there. It has 2 lobes, kind of looks like the letter H, sort of like this. Okay, you have a right lobe and a left lobe with a little connection in between. And that little connection is called the isthmus there. So during an actual live dissection of this gland, it is going to have a reddish color because of all the blood vessels that travel to the gland. And I tell folks, that's another way to tell the difference between the thyroid cartilage and the thyroid gland. Thyroid cartilage is mature cartilage, and so it's avascular. So if you see blood vessels going to something in that vicinity, okay, then you have to assume it's the gland and not the cartilage. All right, so when we take a closer look at the thyroid gland, we'll look at the different cells and the grouping of these cells, all right, these follicles that we'll see. We call the cells in these follicles follicular cells, and they're cuboidal cells. All right, if you recall, some of the functions of cuboidal cells was secretion, and that's what we're going to see here. All right, these cuboidal cells, these follicular cells, surround a central vein because the cells are going to produce and make, all right, our thyroglobulin. And that thyroglobulin, once it gets released into your blood, will be our thyroid hormone here. So inside of these cuboidal epithelial cells, we'll have this protein in there. It's a colloid, which is this protein. It's a viscous, so it's not solid, but it's not quite liquidy. And that's going to allow us to make, all right, this thyroid hormone. Now, around the follicular cells, we have our parafollicular cells, and they're going to make, okay, calcitonin. And we talked briefly about calcitonin in 210 in chapter 7 when we were talking about bone growth. And this hormone, right, is going to be stimulated when we have decreased blood calcium levels, or what you would call hypocalcemia. All right, so decreased blood calcium levels is the stimulus that is going to stimulate the release of calcitonin from the parafollicular cells in the thyroid gland. Keep that in mind because we will talk about it. So here's our picture. Okay, you can see, all right, the thyroid cartilage superior to the thyroid gland here. All right, lots of blood vessels going to the thyroid gland. And in our live dissection, you can see it here. So here are the left and right lobes with the isthmus that connects, right, those two lobes to one another. And then when we look closer on a histological level here, you're seeing now, all right, you have your follicular cells all over the place, right? And in the center here, you're going to have our follicle that's going to be filled with that colloid there. And that's what's going to make our thyroid hormone. And then scattered around, we have our parafollicular cells here and here and here. All right, and those are going to be the cells that are responsible for releasing calcitonin, all right, when your blood calcium levels have decreased. If your blood calcium levels get too high, okay, we'll talk about that, but not yet. All right, let's stay on track here. Okay, so let's start off going through the steps of thyroid hormone being released. Okay, so this whole regulation of the thyroid hormone being released, you should know the term hypothalamic pituitary thyroid axis. And if you look at each of those words in our long hyphenated word structure here, you'll notice each of these are a location, all right, that is going to be producing some sort of hormone that's going to affect another location. So let's start off by looking at our stimuli. So what are some of the stimuli that are going to eventually result in the release of thyroid hormone? Okay, cold temperature, pregnancy, high altitudes, hypoglycemia, which is low blood sugar, and of course, if you have low thyroid hormone floating around. All of those are going to stimulate the hypothalamus to release thyroid releasing hormone, which will then stimulate the anterior pituitary, right, to release TSH, which is thyroid stimulating hormone. And so TSH is going to go into the general circulation, circulate throughout the body, but ultimately wind up at the thyroid gland where the receptors are, and it's going to bind on the receptors of those follicular cells, and it's going to eventually cause the release of thyroid hormone. So when the follicular cells release that thyroid hormone, okay, it is going to release it into the blood in two forms. what we call T3 and T4. And that has to do with bonding of the iodine here in the molecule. All right, so T3 and T4 are going to be dumped into the blood, and then they are going to circulate in the general circulation throughout the body and go towards the cells, all right, our target cells. Now, interestingly enough, both T3 and T4 are going to utilize our blood carrier molecules. So there are a specific type of molecule, proteins, that are going to bond on to T3 and T4 and allow it to circulate throughout the blood. Now, a lot of times when hormones utilize these carriers, they do it to maintain their half-life. So when I say they maintain their half-life, most cases, if they don't have a carrier associated, they break down faster. So the carriers allow them to stay in circulation a little bit longer and increases their half-life from breaking down. So here you can see, all right, our thyroid hormone, T3 and T4. All right, here's some of the stimuli that are going to occur. Like I said, cold weather, okay, pregnancy. All right, what's going on during pregnancy? A baby's growing. And so mom, all right, is going to be growing new tissue to help support that baby, especially in the uterus and in other places. So thyroid hormone helps with that. When you travel to high altitudes, all right, if you're going to go climb K2 or Mount Everest, all right, you're going to be stimulating the release of thyroid hormone. We're going to talk about some of its effects here, okay? But quite often with hypoglycemia, when we get low blood sugar levels, all right, that's when our thyroid hormone is going to be released. So all those stimuli are going to stimulate the hypothalamus to release what we call thyrotropin releasing hormone, or TRH, into our little blood system here, okay? Don't forget about the hypothalamo-hypophyseal portal system. And so it's going to send TRH to the anterior pituitary, and that's going to stimulate the anterior pituitary to release thyroid stimulating hormone. That's going to go to the thyroid gland and then cause the release of thyroid hormone into circulation, either T3 or T4, which is going to be bound to the carrier protein and circulate throughout the body and head out to all these various effectors or target cells. So you can see here in all of the cells, but specifically neurons, it is going to increase the metabolic rate and increase glucose uptake. Neurons love glucose. The brain is a fiend for glucose. That's the preferred energy source for the brain is glucose. In fact, your brain gets first dibs on any available glucose. So thyroid hormone is going to increase metabolic rate. For example, it'll increase protein synthesis inside these cells. For neurons, for example, it helps to make more of our channels. You guys remember the leak channels, the voltage gated channels, all of those channels, the pumps, potassium pumps, all of that stuff. In the liver, okay, remember one of the stimuli is hypoglycemia, low blood sugar. So what do we want to do? We want to increase the blood sugar. So we go to the liver and we tell the liver, all right, liver, we got to release some of that stored glucose, that glycogen there. So we're going to increase glycogenolysis. We're going to break down the stored glycogen and release the glucose into the blood. And we'll make glucose from non-carbohydrate sources utilizing gluconeogenesis. Where at the same time, we're going to stop the creation or the making of glycogen. Okay? There's no point in doing two opposite things. And then, of course, in adipose tissue, increase lipolysis. We're going to release triglycerides, and we're going to decrease the storage of triglycerides. All right, then in our lungs, of course, we're going to see, and the heart, we're going to see an increased breathing rate, respiration rate increases, increased heart rate, and we see an increase in the force of contraction. Usually, when we see that, it's because we want to see more blood coming out of the heart. Well, what usually causes the need to have more blood pumping? Stress, exercise. right? The tissues, right, our cells demand more oxygen if you're exercising. Okay, so how do we get more oxygen out to those tissues? We get more blood to those tissues. So we're going to increase our heart rate and the force of contraction. And you're going to learn all that fun stuff in some of the upcoming chapters. All right, so thyroid hormone is going to arrive at our target cells and bind on. Problem is, all right, T3 and T4 aren't the same molecule. Okay, T3 is going to be the more active form. Okay, but again, both are in circulation. You'll have more T4, right? And so what will happen is the target cells will convert the T4 into T3. Okay, so most of it is in the form of T4, okay, but T3 is the more active form, so we'll still have some of that. All right, so basically, we're going to see an increase in metabolic rate in our target cells, all right, and protein synthesis. And as you know, protein synthesis, we'll see it all over the place. So you can see, for example, in the neurons, we're going to increase the overall metabolism in the neurons, right? But we're going to increase, for example, sodium potassium pumps. And all of this is going to create heat. Because remember, what was one of the stimuli for release of thyroid hormone? Cold weather. Right? And so, as we increase the metabolism in these cells, all right, and we increase these chemical processes are going to make heat. And so that will raise your body temperature. Right? So we'll also need more amino acids for our gluconeogenesis. And of course, we need glucose, sugar, for energy. So we're going to see a lot of these processes in the body that are just imperative, right? That's why the importance of thyroid hormone is, and especially in younger people. I mean, it is important throughout our life, but in younger people, because it's involved in so much, especially during growth, because there are folks, you've heard of dwarfism, okay? And there's various types of dwarfism. In some cases, folks that don't produce enough growth hormone, okay, will be a growth hormone dwarf, anterior, it's called pituitary dwarfism. But there's also the thyroid hormone that folks, we don't see it as often, but if you're not producing thyroid hormone in your younger days, that's another, you can also have a form of dwarfism from that. I don't know why I went off on that. I was just thinking about it. Okay, so some of the other effects of thyroid hormone. Let's make energy. Cell energy is ATP. So in order to do that, the liver is going to, of course, release glycogen. Stop making glycogen, release whatever glycogen has into the circulation as glucose. So now we can make ATP in our cells. Also, all right, remember the best stored form of energy is triglycerides. And so we are going to take what triglycerides that are stored and we're going to put them back out to circulation. Well, at the same time, we're going to decrease, okay, the storage of those triglycerides. This is great because the cells in the body will go after those triglycerides. And remember what a triglyceride is. It's a glycerol molecule of 3 fatty acids. And so the other cells in your body can use, the fatty acids and the glycerol for energy, and that saves the glucose for the brain. Because remember what I told you, the brain gets top billing, and we call that the glucose sparing effect. All right, and then finally, okay, it increases our respiration rate because we need to take in more oxygen because we've increased our oxygen demand, most likely if we're exercising or stressed. And then, of course, we'll increase our heart rate and the force of contraction so we can get more blood coming out of the heart to get those nutrients and oxygen out to the tissues that need it. All right, hyperthyroidism and hypothyroidism. I'm sure you have heard of these. Most likely the latter, the hypothyroidism. But hyperthyroidism, that's when we'll see an increase in production of thyroid hormone. So as a result of that, all right, people's metabolic rate will be increased. And so if they're constantly burning off those nutrients, they're going to have weight loss as one of their symptoms. They will be quite hyperactive, and they will be less tolerant to the heat because their body is like a furnace anyways. All right, so what can cause hyperthyroidism? Well, too much T4 intake there, okay? If we are constantly stimulating the anterior pituitary to release TSH, thyroid stimulating hormone, or of course, if our whole feedback system gets kicked out of whack, okay? So we call this condition Graves' disease. And how I remember it is it'll put you in the grave if you don't take care of it because everything is just on overdrive. So what do? We get rid of the thyroid. Then you don't have any more thyroid hormone. That's a problem. So that treatment is, one, get rid of the thyroid and then put that patient on thyroid hormone supplements. Now, on the other side of that coin, we have hypothyroidism. We get decreased production of thyroid hormone. We see this a lot, quite a bit. A lot of my patients, I can tell you, 1, possibly 2 out of every 4 patients that I see, they have a family history or they themselves have a form of hypothyroidism. And so what they'll complain of is, I feel tired. I'm gaining weight. All right. I'm cold. I just don't have the energy. And they're gaining weight because the metabolism is slowed down because the thyroid hormone isn't stimulating that. All right. So some of the things that can cause that is, well, in order to make thyroid hormone, we need iodine. If you're not taking enough of iodine in, you are not giving your body the ingredients that it needs to make the thyroid hormone. All right. Unfortunately, if the anterior pituitary is not getting stimulated to release TSH, that could be an issue. Post-surgical, sometimes if there's a surgery in that area of the thyroid, it can get damaged. And if that happens, you lose function of the thyroid. And then, of course, you can have your own immune system, an autoimmune condition. Your immune system goes after the thyroid. That's called Hashimoto thyroiditis. And my mother has that. So her own immune system, and of course, normally you'll see Hashimoto thyroiditis in more females because females are more prone to autoimmune diseases. And of course, so what happens when you want to treat this condition is we just give them thyroid hormone replacement. Synthroid is a very popular synthetic thyroid hormone replacement. A goiter, I don't think I have a picture of a goiter. Nope, I don't. Anyways, a goiter is when you're looking at somebody, you see a big lump in their throat. And what happens here is, right, we see an enlargement of the thyroid gland. And normally it's because you are not getting enough dietary iodine. If you ever notice, if you have table salt on your table, usually when you go to the store, people will buy iodized salt. And with the, I won't say the invention of that, but with that product, the creation of that iodized salt product, we have managed to decrease goiters because of that. But normally what we'll see is people aren't making, what happens is they're not taking in enough dietary iodine. And so the thyroid gland is going into overdrive, right? It is just trying to make as much. And so it's growing, it's hypertrophy. So now that we have iodized table salt, don't really have to worry about goiters too much anymore, at least in this country. All right, let's jump back to calcitonin. This is the other hormone that is produced in the thyroid gland. A lot of folks usually get confused between calcitonin and parathyroid hormone because if you recall, the parathyroid glands are in close proximity to the thyroid gland. They're actually on the posterior surface of the thyroid gland. And there's usually 4 of these little parathyroid glands. And so it's the parathyroid gland that makes the parathyroid hormone, which has to do with calcium levels in the blood. Right? If calcium levels get too high, Well, we're talking about calcitonin. This is what happens, all right, when calcium levels, all right, get too low, okay, gets too low. So calcitonin, right, is going to be released from parafollicular cells. Okay, those are those cells that are just kind of scattered throughout. And did I say low? My bad. I'm just reading this and I made a mistake. Calcitonin, all right, is when our blood calcium levels are going to be too high. All right. And that's right, because I meant to tell you this. What does calcitonin do? What it does is it takes calcium out of the blood and puts it into things. That's how I remembered calcitonin, putting calcium into our tissues there. And what are the tissues that hold on to calcium? Bones, big time. Okay, that was one of their functions, was a storage site for calcium and phosphate, magnesium. All right, so when our blood calcium levels are too high, right, calcitonin gets released, and it is then going to then cause the osteoclasts in your bone cells, in your bone tissue, to stop working. Okay, because the osteoclasts, their job is to resorb, all right, bone tissue. And when it does so, it releases calcium. Okay, so if we inhibit them from working, then they're not going to break down the bone tissue. Okay, and so that will then keep the calcium in the bone so we can store more. While that's going on, our kidneys then are just going to pee the calcium out. And that's all that's going to happen. We're going to excrete the calcium in our urine. Say bye-bye, calcium. All right, let's get to some fun stuff here and talk about the adrenal glands. All right, our adrenal glands, all right, also known as the suprarenal glands. Those are the glands that sit on top of our kidneys. And because the kidneys are what we call retroperitoneal, that means they sit behind the peritoneum. The peritoneum is the serous membrane there in your abdominal pelvic cavity. Right? It is retroperitoneal, so it sits behind that. Basically, it's another way of saying, all right, these glands are really posterior, far back in your abdomen. Okay, and so they sit on top of each kidney, and they're embedded in fat, which is great because one of the functions of fat is insulation, but more importantly, cushioning. So they're embedded in that, what we call the perirenal fat. So when we look at our adrenal glands, right, there's two parts to them. There's the outer part, like the crust, and then there's the inner part. The inner part we call the adrenal medulla. We got lots of blood vessels that go there because we have two very important hormones that get released from that region, epinephrine and norepinephrine. Sometimes people refer to this as adrenaline, okay? But it has lots and lots of uses, okay? So epinephrine and norepinephrine are produced by the adrenal medulla through sympathetic stimulation. When we talk about sympathetic stimulation, we're referring to the autonomic nervous system, the fight or flight part, okay? So usually these hormones are being released from a sympathetic response, usually because you need to get up and get out or something. You need to be put on high alert for whatever. Now, the adrenal cortex is the other region here to the adrenal gland, and it makes out the outer shell here of our adrenal gland. And so it makes, all right, over 25 corticosteroid hormones. All right, we're not going to talk about all 25 of them. All right. So what we'll see is, all right, a lot of the adrenal cortex is going to have a yellowish coloration to it because of the lipids that are found there. In corticosteroids, steroid hormones, all right, we utilize cholesterol to make, all right, these hormones. And so we keep that cholesterol in hand or on hand, right? And those lipid cells help us with that. So there's three regions here to the adrenal cortex. You have the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona glomerulosa is the one that's most superficial. It's the outer zone. And then the innermost zone for the adrenal cortex is the zona reticularis. We're going to talk about, okay, what gets produced where in these zonas here. So here you can see, all right, where the kidneys are located. Keep in mind, you notice that the right kidney is lower than the left kidney here, and that's because the liver sits on top. But these glands, the adrenal glands, sit right on top, all right, but far back, far back. All right, so now you can see here's our adrenal gland. You got the two regions here, the medulla here, the adrenal medulla is at the center, and then the adrenal cortex is on the superficial part, on the outer portion. And so when we look at the adrenal cortex here, we see the three zones to it. Here's the capsule. Capsule is usually going to be made up of a dense irregular connective tissue, but it kind of gives a fibrous coating, all right, to our gland, helps with protection and support and yada yada. And then just deep to that is going to be that zona glomerulosa. And then the largest zona is the middle zona, that's the zona fasciculata. And then the innermost zona is going to be the zona reticularis. Okay, so how I remembered it, and again, when we study the kidneys themselves, when we do some renal physiology, you're going to hear a term called GFR. GFR stands for glomerular filtration rate. We'll go into detail about that. But how I remembered the order of these zones here for the adrenal gland, same thing, GFR, glomerulosa, fasciculata, reticularis. Just one of the ways that I was able to relate it, keep it with the kidneys. All right, so let's talk about some cool hormones in the adrenal cortex. We got our mineralocorticoids, our glucocorticoids, and then our gonadocorticoids. It's a lot to say. All right, so when we're dealing with the mineralocorticoids, I always think of the first part of the word here, mineral. All right, I always associate that with electrolytes. So like magnesium, calcium, potassium, all right? I think of those as minerals. All right, so these hormones, these mineralocorticoids, are going to regulate your electrolyte levels. How much sodium is in the body, how much potassium is in the body. That's basically what they do. So aldosterone, and we'll get into more detail when we get into renal physiology, is basically going to retain sodium and it's going to get rid of potassium. Right? So aldosterone is going to retain sodium and get rid of potassium. Now that's important when you are dehydrated, because if you retain sodium, water follows sodium. Water is the follower. I've said this before. It's going to follow glucose wherever glucose wants to go, and it's going to follow sodium. So if you're going to be getting rid of sodium in your pee, you're going to be getting rid of water in your pee. If you're going to be retaining sodium and keeping it in your body, you're going to be retaining water also. So aldosterone plays a huge role in that. That, of course, is found in the outer layer in the zona glomerulosa. Now, your glucocorticoids. These guys play a big role in regulation of blood sugar levels, as does insulin, as does glucagon. Okay, well, your glucocorticoids, again, made by this middle layer, right? One of the more popular glucocorticoids is cortisol. Cortisol is the stress hormone. So if your body's undergoing a lot of physical stress or just from either exercising or just stress in general, you are going to be pumping out a lot of cortisol. And so that is going to increase constantly your blood sugar levels. We get kind of nervous about that because if you're pumping out too much cholesterol or cortisol, right, it can have some deleterious effects on you. And then finally, in our innermost layer, the zona reticularis, is where we have our sex hormones or the gonadocorticoids. Remember that these are sex hormones because the first part of this word contains gonad. All right. So these sex hormones, and specifically if we're talking about androgens, because those are the male sex hormones, right, will be produced here. Some of them will be, I should say, okay? Because also, for example, for males, predominantly the testicles produce testosterone, okay? But, all right, the adrenal glands will produce testosterone also. And so what happens is those androgens, if you're a female, will be immediately converted into estrogen. Okay, so just kind of a little bit of an overview here of the adrenal glands, what hormones are being produced there and where. So let's talk about cortisol release, because cortisol, like I was saying to you, is the stress hormone. And you've heard of cortisol and hopefully possibly in regards to like that stressful hormone, but also you've probably also heard of corticosteroid, because when you hear someone saying, hey, I went in and got a steroid shot, that's what they're talking about. That's what they're referring to. Okay. So these two hormones are going to increase nutrient levels in the blood. And why is that necessary? Well, think about it. Remember what I said? This is the stress hormone. When you exercise or when you're doing like work, physical labor and whatnot, you are, I hate to say it, not on a grand scale, but you are damaging certain tissues. And it's just wear and tear over time as you're running. Okay, you can start to damage. And I don't want you to think it's like irreparable damage, but when you're looking at it from a histological perspective, from like using a microscope, you'll notice that some of these tissues and cells get damaged. No problem. No problem. These hormones, because they increase that nutrient level release into the blood, right? That allows the cells and the tissues in your body to then repair any damage that may have occurred. All right. So how does this all go down? Well, we're going to use, again, we're going to look at how we regulate all this. And here are all the players: the hypothalamus, the pituitary, and the adrenal glands. So the hypothalamic pituitary adrenal axis is how we regulate all of this. So here again, first bullet point, you can see this right here are your stimuli, stress, right? Near the end of your sleep cycle, again, you will also be releasing these hormones, okay? If you have low levels of cortisol, right, again, we're leading back to that feedback mechanism, right? So you see all these stimuli are eventually going to cause the hypothalamus to release, all right, CRH. Again, R in the middle of the name of the hormone tells me that it's a releasing hormone, right? So our chorionic releasing hormone is going to travel down to the anterior pituitary, and it is going to stimulate the release of ACTH. ACTH will then stimulate cortisol and corticosterone being released, all right, from the adrenal glands. And so we'll see cortisol is going to travel through and cause an increase in your blood sugar levels, right? It will be regulated through that negative feedback. So once those blood sugar levels get up to a significant level, right, we can either have insulin being released or we can stop the release of cortisol. So of course, let's look at our picture here. All right, so here's our stimulus, our negative feedback, time of day, and stress. So the hypothalamus, the receptors there, all right, are going to release that corticotropin releasing hormone, that CRH, into our little, all right, blood portal system here. It's going to travel down to the anterior pituitary. It's going to stimulate the anterior pituitary to release ACTH, the adrenal corticotropic hormone. And then, of course, this will travel to our adrenal glands, which are going to stimulate the release of cortisol, right, or corticosteroid, right, into the general circulatory system. Again, we're going to see its effects on our effector target cells here. In the liver here, okay, we want to increase our nutrient levels, so we're going to increase, all right, anything that we can do to break down stored glucose or to make new glucose. And we're going to inhibit any storage processes for glucose. Same thing here when we get to adipose tissue. All right, we're going to increase lipolysis to release, all right, the triglycerides, and we're going to decrease the creation of those triglycerides. And then we'll see, all right, through all the cells here, all right, we're going to increase our protein catabolism. Okay, protein catabolism is the breaking down of proteins into the building blocks of proteins, which are amino acids, because we can use those amino acids to build other things. So you'll see here, if we get too much cortisol, you're going to have water retention. Why? Because we're going to retain sodium. Right? Also, it helps to decrease inflammation. Steroid injection is a wonderful thing for significant acute amounts of inflammation because it stops the inflammatory process pretty much as soon as it begins. Problem is that it will suppress the immune system, and it will cause, right? That's why people on long-term steroid drugs have to be careful, because it will suppress the immune system, and because it inhibits connective tissue repair, their skin, lots of connective tissue in the skin, their skin gets thinner. So folks that take topical steroid treatments over long term have to be careful, because it can thin out their skin in that area because it decreases or inhibits the connective tissue repair. So here you can see a couple of things that influence blood levels of cortisol. Again, we're going to see that it's based on the circadian rhythm. So the time of day will determine when cortisol is being released. And if you notice here, during your sleep time, you notice how cortisol release increases, especially as you get near the end of your sleep cycle. Again, what's going on during that time? Well, that's when your body is trying to repair itself. Okay, sleep is that regeneration and repair processes are going full bore. So cortisol helps with that. And of course, all right, we'll see cortisol levels increase, right, in stressful situations, whether it's through exercise. And this guy here, it looks like he's sweating quite a bit, probably because he's outside chopping wood when it's 95 degrees outside. So when we're looking at the effects of cortisol, all right, as to how it affects the target cells, again, our end goal is to increase blood nutrient levels. Okay, so I already went through all this and what it does to the liver. Okay, it encourages the liver to release glucose into the bloodstream, and it decreases the storing of glucose. Adipose tissue, okay, same thing. We're going to increase triglycerides into circulation. We're going to decrease storing triglycerides right now. And then we're going to break down our proteins through that protein catabolism, because we want amino acids, because then we can use those amino acids to build other things. And in this case, we'll use those amino acids to make, yes, you guessed it, more sugar. All right, so this is all good and well. So of course, we're going to use these types of hormones in the treatment of inflammation, okay, because those corticosteroids will stop inflammation pretty much as soon as it starts. But unfortunately, like I said, it can suppress the immune system. So we have to be careful of that. All right, so that's pretty much cortisol. I'll tell you, hormones are, they're a bear. They're a bear. This chapter here, again, if you get a pretty good basis for it, I know we're throwing a lot at you, but you got this. I trust you. I know you do. All right, so a couple disorders for the adrenal cortex: Cushing's syndrome and Addison's disease. Cushing's syndrome is when we have too much glucocorticoids, all right, being produced, or if you are taking, all right, drugs that mimic, all right, these glucocorticoid hormones. All right, so if you have too much, what we'll see with Cushing's disease is increased obesity, increased blood pressure, okay? Quite a bit of hair growth. Now, the kidney stones is an interesting fact, and it has to do with the filtering process there in the kidneys, of course. And then for females, they'll see changes in their menstruation. Right, but a lot of times what people will initially notice is an increase in weight quite a bit. You'll start to get a lot of fatty deposits around the hips. And in some cases, people will start to notice a humpback, because in Cushing's syndrome there, they'll start to deposit quite a bit of adipose tissue there at the base of the neck. And they'll see quite an increase in their blood pressure. Now with Addison's disease, now we're going to see an insufficiency going on. So usually the adrenal glands will stop to work. Jesus, not to stop to work, they're going to stop working. All right, and so with this situation, we're going to see, all right, a decrease in the glucocorticoids in our middle layer there, the fasciculata. And then with some of our mineral corticoids there in the glomerulosa, all right, we'll start to see, all right, these patients will manage to lose quite a bit of weight. They won't have enough energy, so they'll complain of fatigue and weakness because we're not generating enough nutrients for them, okay? A significant decrease in blood pressure. And we'll also see some skin darkening, and that has to do with the melanin. For whatever reason, it affects the melanin content in the skin there. So easy way to treat this is to give these patients some oral corticosteroids to make up for that shortage of those glucocorticoids because of the zona fasciculata there being affected. All right. So let's go through a couple of the other tissues and organs in our endocrine system that will be producing some hormones. And I have to talk about the pancreas. This gland, organ, we're going to talk about twice. We're going to talk about here in the endocrine system, and then we're going to revisit it when we get into the digestive system, because the pancreas is both an endocrine gland and an exocrine gland. Remember, exocrine glands have ducts, but anything that's affiliated with the exocrine function is usually going to be digestive in nature. So we'll talk about that later on in chapter 26, I believe. We're here to talk about the endocrine. But before I move off of the exocrine, keep in mind, all right, we have two cell types that we're going to focus on, or two a grouping of cells. All right, we have our acinar cells, and these are going to be the ones that have the exocrine function. So again, that's going to be for digestion. We're going to see that, okay, when we're talking about some of the enzymes that are going to be produced. All right, and these are going to make up the majority of the cell structures in the pancreas. So we'll see these clusters all throughout the pancreas, and we call those acini. Now, let's get into the endocrine cells. All right, these are called the pancreatic islets, right, or the islets of Langerhans. Right, so these are these clustering of the endocrine cells. And so there's a group. The first two cell types are the ones that I really want you to focus on, alpha and beta. Alpha cells secrete glucagon, beta cells secrete insulin. We also have the delta cells and our F cells. All right, the delta cells are going to secrete somatostatin, and somatostatin is the growth hormone I, inhibiting hormone. Right, but I really want you to definitely know alpha cells, glucagon, beta cells, insulin. And you'll see this on a test for lab. All right, arrows are going to be pointing to the cell. It's a beta cell, and it's going to say, what does this make? And you should know it makes insulin. And it might even ask you, what does insulin do? And it lowers your blood glucose levels, whereas glucagon increases the blood glucose levels. All right, here you can see where the pancreas resides. sits in between the duodenum, which is the first part of your small intestine, and the spleen. All right, you can see how the pancreas kind of tapers down, and that little skinny end, that's the tail. So the tail of the pancreas is in by the spleen. The head of the pancreas is this big kind of fatten area here. And then we got the body, which is in the middle. All right. So keep in mind what we're looking at here when we're looking at the pancreas, those two cell groups, the acinar cell groups, and then the pancreatic islets or the islets of Langerhans. So let's talk about the importance of how the pancreas is going to maintain the amount of glucose in your blood. It's kind of nice because this organ secretes two antagonistic hormones. One increases blood sugar levels, one decreases blood sugar levels. And we have to maintain healthy number, all right, when it comes to blood glucose levels. Too much can literally shred your kidneys, all right, but also can cause damage to your blood vessels. Long term, if it causes damage to the blood vessels, all right, then you get inappropriate or insufficient blood flow to an area. And guess what follows that if it's not taken care of? Possible amputation. Okay, that's not good. All right, so high levels of blood glucose can cause damage to the blood vessels and the kidneys. Low levels, okay, tiredness, lethargy, mental and physical impairment, where these people were just out of it, might not even know, and God forbid, death. So it's important. So let's talk about it. All right, so we're going to start off and talk about insulin. This is the hormone that's going to lower our blood glucose levels. So you have a nice meal, okay? Doesn't matter if it's a high sugar meal, but let's go with that. Let's say I'm going to run a race this weekend coming up, and I want a carbo load. I want to eat a lot of pasta, a lot of starch, and get my carbohydrate macromolecules in high presence in my blood. So after I eat my meal, okay, the beta cells in my pancreas start to pump out insulin because they've detected that there's been an increase in blood glucose levels because of that very high in carbohydrate meal that I just ate. So glucose levels increase and insulin levels will also increase. And so what will happen is insulin will travel all throughout your general bloodstream and it'll go towards target cells. All right. Here with insulin, it operates through that secondary messenger system. So you remember how that system works, okay? It can't physically enter into the cell. It needs to stimulate the activation of G proteins and certain enzymes in the plasma membrane to stimulate the activation of other enzymes inside the cell, okay? So as a result, all right, this secondary messenger system kicks in, and what will happen is, all right, our blood glucose levels start to fall. How does that happen? Well, those cells will start to absorb and take in, all right, glucose. And as the blood glucose levels fall, the beta cells will then stop producing insulin to kind of keep us within, like I said, this normal range, 70 to 110, right? That's how much we want to always trying to manage. Remember, homeostasis. We want to maintain that healthy operating range there and kind of flow back and forth in there. All right, so let's talk about specific now cells throughout the body that insulin is going to affect because of these high blood glucose levels. So the liver is going to take that glucose from the blood, and guess what? It's going to store it as glycogen. Remember, glycogen is the stored form of glucose. So all the way up to this point, we were talking about how we haven't been storing glucose. In fact, we're trying to get glucose into the bloodstream. Well, now we're going to take glucose out of the bloodstream and we're going to store it, okay, in the liver. So that means we're going to make glycogen. So we're going to stimulate glycogenesis, or at the same time, we're going to inhibit the breakdown of glycogen through the process of glycogenolysis. And we're going to stop making glucose from non-carbohydrate sources like amino acids. So we're going to inhibit gluconeogenesis. At the same time, too, because not all meals are 100% carbohydrates. They're going to be proteins. Okay, there's going to be fats in there too. So our adipose cells now are going to start to absorb, all right, any fatty acids that may have resulted from that meal that we had. So we're going to store those fatty acids as triglycerides. So we're going to stimulate lipogenesis, and we're going to inhibit lipolysis. And then now when we're looking at pretty much all the other cells in the body, same type of situation. These cells are going to uptake those nutrients floating in the general bloodstream there. So we're going to see an increased amino acid uptake, which means let's take those amino acids and use them to make something. Okay, let's make proteins. And so we'll make some awesome proteins in muscles with actin and myosin. That's always a good use. We'll also see, okay, with insulin, an increase in that glucose uptake by making more of these glucose transports. Well, guess what? Glucose transport proteins, all right, are going to shuttle glucose across the plasma membrane. Glucose is too big, all right, to go through the plasma membrane on its own. So it needs a little bit of help. It needs some, we call that facilitated diffusion, and that's what we're going to see. As long as there's more glucose outside the cell than inside the cell, it'll be, as long as those transport proteins are there, it's going to shuttle glucose into the cell, which is, the cell loves all that kind of stuff. All right. And just kind of like an FYI, I always found this to be interesting. Yeah, definitely interesting that some cells don't even need insulin to take in glucose. And of course, this makes complete sense. Neurons, all right? Your central nervous system, brain and spinal cord, all right? They don't need insulin to take glucose in, okay? Because they don't need to be hindered in any way, shape, or form from undergoing metabolism. Right. Also, we'll see that in the kidneys, also in our liver cells, and then, of course, red blood cells. So here's that picture here of what's happening here with insulin. Okay, stimulus, we have high blood sugar levels. The pancreas then, all right, senses that. The beta cells then start to produce and pump out insulin into our general bloodstream here. And of course, we just talked about all the effects that insulin has on these different tissues here. All right, so again, then once the blood sugar levels start to drop, then through the negative feedback system here, all right, our insulin levels will start to drop, all right, to get those blood glucose levels back to that regular normal level there. So of course, what happens when all of this goes wrong? There's a condition you've heard of, diabetes, all right? So we have diabetes mellitus, and basically this is what happens when we are unable to govern or correct blood sugar levels. And so what will happen is, right, for whatever reason, right, insulin is not helping, all right, to decrease those blood sugar levels. So of course you'll have elevated blood glucose levels, and we'll see as time goes on, those blood vessels start to get damaged. The nervous tissue starts to get damaged. So people, you might have heard of diabetic neuropathy. So long-term chronic exposure to elevated blood glucose levels will cause this type of situation. Number one cause of retinal blindness is from diabetes. Kidney failure, all right, is also going to be, all right, a possibility if this is not corrected, because glucose is constantly being spilled out through the kidneys, and it can damage those tissues in the kidneys and eventually cause kidney failure. All right, so we also have to take into consideration heart disease and stroke. So type 1 diabetes is when the pancreas is not making any insulin, or very little, and it really does not have an effect on blood sugar levels. So of course we see this in younger individuals and children. right? And so these are the patients that actually will need injections of insulin regularly to help monitor that. And then, of course, there's the insulin pumps that people use, which is that's helped to make type 1 diabetes much more manageable. It's a very difficult condition to deal with, especially in adolescence, because there's a constant fluctuation of other hormones that can act antagonistically with insulin. So the pump has helped tremendously. Type 2 diabetes, we've seen this quite a bit in obese population and older folks, all right? And so in this scenario with type 2 diabetes, all right, we will see a decreased amount of insulin that's being released from the pancreas. But what we'll see is that the target cells, that insulin seems to not be effective. All right, so it decreases the effectiveness of insulin on those target cells. So we'll see this in older people, right? And so normally this type of diabetes can be treated through diet and exercise, but in some cases we do have to give medications like metformin or glucophage to help with, all right, decreasing the blood sugar levels there. And then gestational diabetes, we'll see this in pregnant women. In fact, my mother, I believe, had gestational diabetes, okay? And so unfortunately, all right, because of gestational diabetes, one has to be careful because those folks are more prone to type 2 diabetes later on. And not just that, the fetus can also be more prone to type 2 diabetes. So here's the definition of hypoglycemia, okay, low blood sugar levels, glucose levels fall below 60, all right, milligrams per deciliter. Normally 70 is the low end of our blood sugar levels, all right? And so in some cases, all right, what can cause this? Well, if there's too much insulin, okay, that's going to drop your blood sugar levels quite a bit. Prolonged exercise, all right, because those tissues that you're using during exercise are pretty much just sapping all the nutrients out of circulation. Alcohol use, liver or kidney dysfunction. So in these patients, obviously they're going to get hungry because we're depleting their nutrients, right? But they may see that they start to have dizziness, all right? Cold sweats. Some of you may have experienced hypoglycemia. I've experienced it quite a bit when I was younger. If I would go shopping with my mom, because she loved to shop, and if I didn't eat before I went out with her, because something that could take 1 or 2 hours, shopping with my mother when I was younger would take anywhere from 4 to 6 hours. So she would always feed me, so I wouldn't get hyperglycemic. Okay, but of course, if you come across somebody, they're unconscious, and it's hypoglycemia, all right, you give them a little blast of glucagon, all right, and that can help, all right, increase the blood sugar levels. And I'm going to tell you how we're going to do that right now. All right, so when your blood sugar levels start to decrease, you have hormones that help to increase, all right, those blood glucose levels. Glucagon is one of those hormones here, all right? So the alpha cells in the pancreas, all right, are going to detect when your blood glucose levels drop. And when that happens, it releases glucagon. Glucagon also is going to utilize those secondary messengers, all right? And it is then going to then tell certain tissues to release their nutrients. Now, I think you can pretty much figure out the pattern here. When we're dealing with the liver, we need to increase blood sugar levels. How do we do that? Okay, we are going to break down stored forms of glucose, all right, and we're going to enact gluconeogenesis. So we're going to stimulate those two processes while at the same time, we're going to inhibit glycogenesis. We're going to stop making glycogen. And then in our fat tissues, okay, we are going to release, all right, the triglycerides into the blood. So we need fatty acids and glycerol, so we'll break down, all right, the triglycerides, and we will stop storing them. All right. To note, though, glucagon does not affect protein. All right, that is one thing that you want to make a note of. Okay, it does not affect protein. So, of course, ask any paramedic, and some of you may already know this, or an EMT about glucagon. All right, if you come across an unconscious individual and they have low blood sugar, you can actually go ahead and you can go ahead and give them the glucagon there. Okay. All right, so you can see here, all right, once those blood glucose levels start to increase, all right, glucagon will then be released. Janelle, you gonna get that? Sorry, there's a person at our front door. All right, sorry here. So basically, kind of like what we saw here with insulin, okay? So the pancreas here, the alpha cells are going to detect, actually stop. The pancreas, all right, is going to release glucagon because the alpha cells detect a decrease in blood sugar levels. And then it releases glucagon, and of course it goes off into circulation. And basically what we just talked about with the target cells, we'll see, all right, glucagon is going to release, all right, glucose from the liver, and then it will release fatty acids and glycerol from our fatty tissue. And then through the negative feedback system, Roxy, enough. All right, through the negative feedback system, all right, once the blood sugar levels get into that normal range, then our levels of glucagon will decrease. Almost done, folks, almost done. All right, the pineal gland, okay? This is part of the epithalamus. Remember the three parts to the diencephalon? You've got the hypothalamus, all right, the epithalamus, and the thalamus. Well, the pineal gland is one of two parts of the epithalamus. Its job is to secrete melatonin. All right, melatonin is that hormone that helps us to regulate our circadian rhythms, our sleep-wake cycles. Also, it does have an effect on our mood, okay? And so melatonin, right, I don't know about you, but sometimes people have difficulty falling asleep, and so they'll take melatonin supplements to help facilitate that. Well, your body makes its own melatonin through the pineal gland there. All right, you heard me mention earlier about the parathyroid glands. All right, these are these little glands that sit on the posterior portion of the thyroid gland. Normally there's 4, could be as low as 2, but as many as 6. All right, and they have, all right, a couple cells here of note. You have your chief or principal cells, and they make the parathyroid hormone. And this is the hormone when your blood calcium levels, when you're hypocalcemic, when your blood calcium levels are low, this hormone here, all right, is going to be released, and it's going to help increase your blood calcium levels. How does it do it? It's going to stimulate the osteoclasts in your bone to start to break down the bone tissue. And in doing so, it will increase calcium into your blood. And at the same time, it's going to stimulate, all right, the kidneys there, all right, to retain calcium. So you're going to excrete less calcium through the kidneys and help to bump up your blood calcium levels in your blood. And if you forgot what calcitriol is, that's that vitamin D that we talked about. And the calcitriol is going to help stimulate the absorption, all right, of calcium through your intestines. All right, so finally, a couple other structures that are going to have endocrine functions. The thalamus, right, which is this small little gland that sits superior to the heart there, right? This, and we'll talk about it a little bit more when we get into the immune system, right? But this is where, all right, your T lymphocytes, some of your T cells go to grow up. And once they mature, then they're going to get tested. And if they pass the test, they live and they go out into the body. If they don't pass the test, they die. Anyways, this gland or or tissue here is going to release thymic hormones, which is going to help with those T lymphocytes there. Believe it or not, your heart isn't just a pump, but it also has some tissue, some endocrine tissue, all right, that is going to affect your blood pressure. All right, and so this tissue is going to secrete ANP, which stands for atrial, all right, natriuretic peptide. This hormone helps to lower blood pressure. See, what happens is when your blood pressure increases, it puts pressure onto the walls of your heart and on the walls of your blood vessels. So as you increase the pressure, all right, and for your blood pressure, that pushing on those walls becomes greater. So these tissue cells, all right, will feel that increased pressure and they'll start to secrete this hormone, and that hormone will help to decrease the blood pressure, and it does so by causing vasodilation, and also causes your kidneys to increase urine output. So you're peeing more. And then, I don't know about your kidneys if you've ever heard of EPO or erythropoietin, but this is a hormone that when your blood oxygen levels are low, okay, what carries oxygen in your blood? That's going to be your red blood cells, okay? So if there's a significant demand for oxygen on your tissues, right, your kidneys will start to produce erythropoietin. And that erythropoietin will stimulate your red bone marrow to start making more red blood cells so we can carry more oxygen. All right, liver we talked about before with the insulin-like growth factors 1 and 2, all right, but also it's going to make angiotensinogen. Now, angiotensinogen plays an important role, all right, because one, it's an inactive hormone when it's made by the liver. And so it goes into general circulation and it's going to travel to a couple places. It's first going to travel, all right, to the kidneys, and the angiotensinogen will then get converted into angiotensin 2, all right, and then eventually, angiotensinogen 1, and then from there, it goes to the lungs where it gets converted into angiotensin 2. That's the ultimate hormone that we want to have. And angiotensin 2 will increase blood pressure, right? For whatever reason. If you've been stabbed or whatever, you're losing blood, right? And your blood pressure starts to fall, angiotensin 2 levels will increase to help raise your blood pressure, all right, through vasoconstriction, and at the same time, it will then decrease the amount of urine that you are producing to help increase your blood volume. And while at the same time, it'll make you thirsty. All right, stomach also produces, not also, but it produces several different enzymes and hormones and whatnot. And gastrin is one of these hormones, and we'll talk more about it when we get into the digestive system. But gastrin is a hormone that's going to increase secretion, all right, of some of the digestive enzymes in your stomach, but also it's going to increase the motility of the stomach. Because I want you to think of your stomach as a cement mixer. You know, you've seen those cement mixer trucks driving around. They got that big spinning drum, which is mixing the contents there. Well, that's essentially what your stomach needs to do to any of the food and liquid contents there. It needs to mix all of that together. So gastrin helps to stimulate that motility so it can mix all that, but at the same time helps it to release hormones and digestive enzymes to break some of that stuff down. I promise you folks, we're almost to the end here. Small intestine, all right, we'll talk more about this in detail in chapter 26, but small intestine is going to secrete secretin and cholecystokinin, also known as CCK. All right, secretin is going to stimulate, all right, the secretion of bile and pancreatic juice. Bile and pancreatic juice are two substances we'll get into more that are going to help to break down, all right, food that you've ingested. All right, bile helps to emulsify, really with fat breakdown. Pancreatic juice, I mean, that's going to help with a lot of the digestive enzymes of carbohydrates and proteins and whatnot. And then CCK, cholecystokinin, all right, is going to stimulate the gallbladder to release bile. The liver makes bile, but it's the gallbladder that stores it and concentrates it. So when you have a meal, Okay, this cholecystokinin will stimulate the gallbladder to contract, and the gallbladder will spill that bile out into the small intestine and mix it up with whatever food products that you've made. All right, we've learned about vitamin D3 last semester in 210, calcitriol. Your skin makes vitamin D, and then vitamin D goes into circulation, and it has to go to a couple different areas. First, it goes to the liver, in which it gets converted into calcidiol, okay? And then it's when it makes it to the kidney that it gets converted into the active form of calcitriol. Okay? And it's calcitriol that's going to increase your blood calcium levels, and it does so, all right, by increasing calcium, all right, absorption from the intestine. All right, and then finally, adipose tissue. All right, we have this substance called leptin, and leptin helps to control our appetite here. All right, so folks in general that have a lower body fat are going to produce less leptin. And so if they're producing less leptin, that's going to stimulate their appetite less often. Okay, so unfortunately, all right, folks that have high body fat or obese, they lose that sensitivity, okay, to the leptin, like a type 2 diabetic would. All right, so unfortunately, okay, because they lose that sensitivity, their appetite is going to be stimulated when it shouldn't be stimulated. And that can be an issue there. All right, so we have to be careful, because when we're dealing with adipose tissue, all right, if you have too much adipose tissue, it's going to put you at risk for several things. All right, obviously we've got cancer, all right, and the litany of other health issues, okay? But also for males, we can see a delayed onset of puberty. And if that is the problem, then that we could see a decrease in certain male androgen productions, right? And then now if we go to the other extreme, folks that have too low of adipose levels, for women, it can interfere with the menstrual cycle. And in some folks, like folks that have eating disorders, all right, you have anorexia nervosa and bulimia, and those types of eating disorders can actually cause grand upsets in the menstrual cycle for those patients. Breathe in, breathe out. All right, I know that was a long one, and I feel like you folks did great, okay?